we will put 2 minutes on the clock and your time starts now. Michael Thompson is a 68-year-old man presenting to general practice with complaints of frequent urination, especially at night, urgency and a weak urine stream. He has also noticed intermittent blood in his urine. He has a history of hypertension and type 2 diabetes for which he takes metoprolol and metformin respectively. On examination, Michael appears generally well. Abdominal examination is unremarkable. Digital rectal examination reveals a smooth and large prostate. His temperature is 36.8, blood pressure is 140 on 80, and heart rate is 72. Respiratory rate is 16, and BMI is 27.5. The remainder of his examination is unremarkable. Oh, and these answers already up there, well spotted. So, in the interest of time then, don't you love it when best laid plans fall apart? So this would be a case where they're leading you towards that BPH kind of picture with lower urinary tract symptoms. In fact, let's just skip ahead to here. Now, the other things that you would be wanting to keep in mind with hematuria is going to be prostate malignancy. Particularly in this age bracket, we have an older male who is going to be at high risk, particularly with these issues of weak urine stream, blood in the urine, and the increasing nocturia, particularly with urgency. Something we, of course, can't rule out would be a simple urinary tract infection. And so, again, we're going to the probability diagnoses you'd want to rule out, and that's a simple one we can do. Now, urolithiasis or kidney stones or bladder stones can also be another cause for hematuria. Now, they haven't specified that there's any significant pain there, and while you would normally expect to see pain, and usually not insignificant pain with kidney stones or bladder stones, you can actually have these kinds of responses in the setting of urolithiasis. So a more painless setting, but presenting with hematuria. And of course, we're getting into that age bracket as well, where it's potentially more likely to be presenting with urethral strictures, and one of the complications over time can be hematuria and bleeding. Now, we do have a question pop up there. Whoop. Sorry. Helps when you hit the right button, hey. About, would prostatitis attract a mark for this question? Now, one of the things you would certainly expect to see with prostatitis would be tenderness on palpation of the prostate on the DRE, and they haven't specified that, and so I think it would be significantly less likely to be prostatitis. If there was mention of tenderness, then I think you would be more likely to get the mark for there, in particular if there was any talk of penile discharge on palpation as well. But given they haven't mentioned any of those things, the probability diagnosis places that less likely. All right. Now, I'll just quickly have a look at the next screen. No, good. I didn't put the answers on that one. Trying something new. Let's try it out. Crazy talk, I know. But let's put 2 minutes on the clock. And, of course, your time starts now. You perform a urine ward test which is positive for hemoglobin 3+, but otherwise normal. What initial investigations would be appropriate for Michael? List 5 investigations. All right, so some awesome answers coming through. And this is another one of those situations where there are, again, more possible correct answers than you have options. So they often do give us that little bit of wiggle room in case there is some variability. And sometimes there are just more appropriate tests to be ordering than the options they give us in terms of answering those questions. So we have CFIKO. Now, this is one trap where we have to consider our risk stratification. So in this situation, we have someone who is 68 years old, and so they're going to be in that higher risk bracket for urothelial or bladder malignancy. And so in that setting, it's actually recommended to move straight to the CT IVP, CT intravenous pyelogram. Now, for some reason, the college always harps on about, where is it? Avoiding abbreviations, and yet they are always happy to use CT. Now, if you are writing out the answers for, say, a written answer, I would be specifying computed tomography, intravenous pyelogram. Don't get too caught up on spelling. Your spelling doesn't have to be perfect as long as you can get the vague intention across of what it is you're actually trying to write. Now, we also had ACFKO. So yes, ACF. Full blood count, while you certainly could do it if you had to choose from some of the other options, I would probably be switching to other things. And where are we for? Oh, yep, urine cytology, fantastic. And, of course, ACFMO, well done. Smashing it. Well done to all of you. Now, I want to point out with the cytology as well. Oh, pardon me. Sorry, guys. So cytology does have a high sensitivity in the detection of high-grade bladder tumours, in particular your CIS. It has low sensitivity for low-grade tumours. And so as such, it's not recommended for a sole diagnostic tool, but can be a helpful adjunct for anyone that you're going to be considering referring on for cystoscopy, which is obviously going to be this kind of presentation. In particular, if they do have those additional risk factors for CIS. All right, now moving on then to the final part of the question. 2 minutes on the clock, your time starts now. Your investigations return positive for urinary tract malignancy. Michael is distraught and asks if there was anything he could have done to prevent this. You discuss his potential risk factors for urinary tract malignancy given his hematuria. List 4 specific risk factors for urinary tract malignancy in patients with hematuria. Okay, time is up. Let's move on through to the answers, and loving your answers coming through. So, as you've got down there, so age is going to be one of our first things, and they'll find that they'll tend to put down age 40 or age 50. It really depends which guidelines and which kind of patient demographics you're looking at, and so advanced age or older age would be a perfectly acceptable answers. 100% correct in terms of dye exposure, and I really love as well that you were nice and specific there, giving a specific example by saying the dye, given that is a very well-known association. History of cigarette smoking, history of pelvic radiation, definitely, and older age. So very good answers there. Also seeing coming through, age more than 40, smoking, exposure to chemicals, family history of urothelial malignancy, definitely to all of those. Now, I would just be mindful, exposure to chemicals, if you can, again, being specific, trying to focus in, if you know an example, give it, but you're more likely to get a full mark over, say, half a mark or 2 marks rather than 1 mark by specifying an example in your answer. And coming through, we have the abdominal radiation, smoking, family history of kidney, bladder cancer, chronic inflammatory state, e.g. lupus. Yes, now more than just that though, I think you could specify history of chronic UTIs. So local irritation, local inflammation is also going to be pro-oncogenic, and so you can actually just specify that down. Now, a couple of ones that didn't get mentioned there is, of course, cyclophosphamide exposure. It is one of the things we look out for in any patients that have been exposed to cyclophosphamide. No, that's it. You guys smashed all the other ones. Of course, history of gross hematuria and irritative lower urinary tract symptoms are also those red flag tickets into there.